Okay, thank you all for being here, and the Senate Committee on Health, Education, Labor, and Pensions will come to order. This morning, we will be considering the nomination of Dr. Monica Bertagnolli to serve as the Director of the U.S. National Institutes of Health. And let me begin by welcoming Dr. Bertagnolli to our committee. We look forward to hearing from you, and we thank you for being here today. And I see you brought along a fellow Wyominger, is that what it is? Ites. We welcome Senator Brasso as well. The NIH, with a budget of more than $47 billion, is the largest funder of medical research in the world. This research has led to new treatments and prescription drugs that have significantly improved the lives of Americans and people throughout the entire world. And I think all of us, every single American, should be very proud of those accomplishments. But having said that, let me say a few words about my concerns. I don't have to tell any American that the healthcare system in our country is broken and it is failing. We spend almost twice as much per capita on healthcare as any other industrialized nation, yet we have 85 million people who are uninsured or underinsured. We don't have enough doctors, nurses, dentists, the mental health specialists. Our life expectancy is lower than other major countries and is actually in decline today. And very relevant to the hearing that we are conducting right now, we spend as a nation the highest prices, we pay the highest prices in the world for prescription drugs, in some cases 10 times more than the people in other nations. While the largest drug companies made over $112 billion in profits last year and pay their CEOs exorbitant compensation packages, 1 out of 4 Americans cannot afford to pay for the medicine they need, and thousands of families face financial ruin as they pay prices that they cannot afford for the prescription drugs that keep them alive. Think about it for 1 second. Millions of people get sick, they go to the doctor writes out a prescription, they cannot afford to fill the prescription the doctors write. How insane is that? But it's not just the high cost of prescription drugs impacting individuals. In the largest hospital in my state of Vermont, and I don't think it's terribly different elsewhere, the high cost of prescription drugs account for 20% of the overall budget for the hospital, and that drives insurance costs up as well. Prescription drugs impact hospital costs big time. In other words, the outrageously high cost of prescription drugs in America is a crisis, and it must be addressed. Adding insult to injury, not only has the federal government not effectively regulated the price of prescription drugs, but the taxpayers of this country have, over the years, provided hundreds of billions of dollars in research and development into new prescription drugs that have provided enormous benefits, financial benefits, to some of the most profitable pharmaceutical companies in the country. For example, in America today, the median cost of new cancer drugs has gone up by more than 300% over the past decade, even though 85% of the initial foundational cancer research is funded by the U.S. taxpayer. We are putting money, rightfully so, into research to deal with cancer, and yet we pay outrageously high prices. In June, this committee released a report that found that the average price of new treatments that NIH scientists helped invent over the past 20 years is $111,000. In virtually all cases, American taxpayers are paying far more than people in other countries for the exact same medicine that the NIH and taxpayers helped develop. Here are just a few examples from this report. Astellas and Pfizer charge Americans with prostate cancer over $165,000 for Xtandi, while the exact same drug can be purchased in Japan for just $20,000. This is a drug developed by American taxpayer dollars. Johnson & Johnson charges Americans with HIV $56,000 for Simtuza, while the same exact treatment can be purchased in the UK for just $10,000. Product developed by U.S. tax dollars. Gilead charges Americans with non-Hodgkin's lymphoma $424,000 for Yescarta, while the exact same therapy can be purchased in Japan for just $212,000. And the list goes on and on and on. We pay for the research. Drug companies develop the drug, they make billions, and then they charge us the highest prices in the world for the product. One last example. After receiving $12 billion from the federal government, Moderna has quadrupled the price of the COVID vaccine, a vaccine that was literally co-invented by NIH scientists, to $128, while the exact same vaccine will be available in Europe for as little as $26. Really? Anybody here think that vaguely makes sense? We develop the research, we pay for it, we pay the highest prices in the world, our people can't afford it. Doesn't make sense to me. In my view, at this very difficult moment for American healthcare, and we are in a crisis situation, we need an NIH director who is prepared to take on the greed of the pharmaceutical industry and use every tool at his or her disposal to substantially lower the outrageous cost of prescription drugs. The 1,800 well-paid lobbyists from the pharmaceutical industry are all over this place, may not be happy about that thought, but that is precisely what the American people want. The status quo is not working. We need fundamental changes in the way that the NIH addresses the crisis of prescription drugs. We need an NIH director who is prepared to reinstate and expand the reasonable pricing clause, to make sure the pharmaceutical companies set reasonable prices for new prescription drugs developed with taxpayer support, et cetera, et cetera. The whole lot of things the NIH can do. Now, is the NIH alone going to solve the problem? Of course not. Other agencies, the administration has got to be active as well. You know, the media describes what goes on in Congress as we are a very divided nation. Well, we are. But I will tell you this, whether you're a conservative Republican, a progressive, a Democrat, or an independent, you know what we all agree on? Every poll tells us that. And that is the American people want the Congress to deal with the outrageously high cost of prescription drugs. That is what we have got to do. Senator Cassidy, you're recognized for your opening remarks.
Thank you, Chair Sanders. Today, the committee considers the nomination of Dr. Monica Bertagnolli to be the next director of the National Institute of Health. And Dr. Bertagnolli, thanks for being here. Thanks for taking on this job and going through this committee, which I know must be stressful, but again, very pleased to have you. You have an incredibly impressive resume, and I say that as a physician who formerly was in academics but has no resume that compares with yours. And it's reflected by the support that you have from the scientific community. There's no questions regarding scientific qualifications, but there are people that will ask questions regarding your overall ability to lead the NIH in the next phase, and this is what my remaining remarks will be about. Everybody knows the NIH's role in strengthening America's biomedical research and supporting public health, especially during a crisis. Unfortunately, it became a lightning rod for partisan debates during the COVID-19 pandemic, and that eroded the trust between the NIH and the public. First and foremost, you will be tasked to rebuild the relationship with Congress and the public, being a leader that represents the interest of all Americans and not just of the scientific community. This means making the agency more transparent and accountable to Congress while also advancing cutting-edge science, effectively communicating to the American people and rebuilding trust between public health officials and the biomedical research community. The NIH director must also protect and strengthen the valuable public-private partnerships that make up our biomedical research enterprise. And sometimes that public-private partnership is underestimated, but clearly the private and the public partnership has been what has made the United States a leader in innovative drugs. Last month, I issued a request for information from stakeholders on modernizing the NIH, and this will include buy-in from all. I look forward to hearing from you about your vision for the agency and how you shall achieve. Now, during our meeting, we spoke about bioethical issues, including fetal tissue and embryonic stem cell research and the use of hormones and other gender transition interventions on children, like on children. Frankly, at times you avoided getting into specifics, citing a lack of expertise. But as the director, you will have to have this expertise. You will need to be prepared to weigh in on topics that not are in your research specialty, but across the entire enterprise, making the policy decisions that will shape the direction of biomedical research. While you will consult with experts and take input from your institute directors, you're ultimately the person who decides. I point out that this hearing is apparently happening today. It was not going to otherwise. Because of a publicly acknowledged deal the Biden administration cut with Chair Sanders to implement partisan drug pricing policies in exchange for advancing your nomination. Biden administration officials told us in a hearing earlier this year that policies similar to those in the deal that have been reported could risk future partnerships between the government and the private sector. By the way, future partnerships critical to generating the cures important for cancer and Alzheimer's and for the next pandemic. The partnerships that are the foundation of the U.S. biomedical research enterprise, which, by the way, leads the world in developing these cures. It's concerning that the administration would jeopardize the long-term success of this enterprise for the short-term goal of advancing your nomination. Last week, I asked President Biden and Secretary Becerra for a full accounting of any deals cut with members of Congress relative to advancing your nomination. At 5:43 last night, this is kind of the problem. At 5:43 last night, I received basically a form letter that provided no information and intentionally ignored the request it was supposedly responding to. The administration was not forthcoming about any deals with members of Congress, even though some of those details have been reported in the press. Now, senators expected to vote on your confirmation should be aware of any such deal prior to the nomination. That's not you, it's the process. And when we speak about the breakdown of trust, it's like rhetoric, inflammatory rhetoric, which is true, but not related, is driving a process by the administration on something that we should know about, but we're not being told. Another example, in June, Senator Tuberville and I sent the acting NIH director a letter about NIH-funded projects that resulted in the death of 2 adolescents. We didn't get a response to that letter till September 15th, a week after the Biden administration struck the deal to move your nomination. I believe you when you say that you're committed to transparency and rebuilding the NIH's relationship with Congress. I appreciate that commitment, but I have concerns given the administration's history of failing to respond to congressional oversight requests, particularly from members of this committee who are responsible for that oversight. So rebuilding the NIH's relationship with Congress will require a strong director who can overcome partisan divisions, overcome the administration's deliberate stonewalling of requests from members of this committee for that information pertinent to the work of this committee, and work with both Republicans and Democrats to improve trust in our federal health institutions. That means being open and responsive to this committee, which will directly oversee your work as NIH director if you are confirmed. I look forward to hearing how you shall fulfill these parts of the job and move the NIH forward. I thank you, and with that, I yield.
Thank you, Senator Cassidy. I'd now like to welcome our nominee, Dr. Monica Bertagnolli, has served as the director of the National Cancer Institute since October 2022. Prior to that role, Dr. Bertagnolli was a surgeon at Brigham and Women's Hospital and the Richard E. Wilson Professor of Surgery in the field of surgical oncology at Harvard Medical School. Dr. Bertagnolli is a longtime member of the American Society of Clinical Oncology, where she has served as both president and a member of the board of directors. I thank her for being here today, and I now turn it over to Senator John Barrasso to introduce her. Senator.
Well, thanks so much, Mr. Chairman, and I'm pleased to welcome to the Senate and to the committee Dr. Monica Bertagnolli, who is a fellow physician and a Wyoming native. President Biden has nominated her to be the director of the National Institutes of Health. And it's certainly not every day that one of Wyoming's very own is nominated for such a high position in our nation. Dr. Bertagnolli has devoted her entire life to medicine and medical research. She earned a bachelor's degree in engineering from Princeton University, graduated from the University of Utah's Medical School, and completed her surgical residency training at Brigham and Women's Hospital in Boston. She then went on to be a research fellow in tumor immunology at the Dana-Farber Cancer Institute in Boston, and she later served as the chief of surgical oncology for over a decade. She's continued caring for patients at Brigham and Women's Hospital while being a renowned cancer researcher. She's also served as a professor in surgical oncology at Harvard Medical School. She's trained not only the next generation of doctors, but also cancer researchers. And this makes her a perfect fit to serve as our current director of the National Cancer Institute. While many may know that she is a well-respected physician and researcher that she is, Wyoming knows her as part of a multi-generation ranching family. And I'm proud to say that she has never forgotten where she came from. As I've traveled and met with folks across Wyoming and the Mountain West, I've heard of her great work not only as a doctor, but also on the ranch. So that includes the ranch neighbors. If you want to know about somebody, you talk to their neighbors and the ranching neighbors. They speak of her grit, her endurance, and her determination. Her commitment to the land and the livestock speaks volumes about her character and her courage. She understands the needs of rural health and of frontier medicine. She has used her background, medical as well as the values that she learned growing up, to improve health care for all Americans. She serves as an advisor to the Huntsman Cancer Institute in Salt Lake City, Utah, which is a designated cancer institute for Wyoming. She also advised Huntsman on how to reach patients in rural areas. She focused on reducing burdens on patients by using local cancer treatment clinics. One is in the Sweetwater Regional Cancer Center in her hometown of Rock Springs, Wyoming. Her firsthand experience in accessing health care in rural America gives her a perspective that is often lacking in Washington. She has an extensive track record of cultivating private-public partnerships to push medical innovation forward. I know this background will serve her well as the director of the National Institutes of Health. I have tremendous appreciation and admiration and respect for Dr. Bertagnolli. And with that being said, Mr. Chairman, I do have serious concerns about the way this administration has handled the COVID pandemic, has politicized government agencies such as the NIH, has attacked health innovation through the Inflation Reduction Act. I think it's important that this position be filled with someone with a critical and an open mind, ready to tackle the important challenges ahead. And for all these reasons, Mr. Chairman, I support the nomination of Dr. Monica Bertagnolli to serve as the director of the National Institutes of Health. Thank you, Mr. Chairman.
Thank you, Senator Barrasso.
Mr. Chairman, can I ask a quick question? Do you have to be Italian to be from Wyoming? You know what I'm saying? I'm just thinking that.
Well, in a bipartisan way, it
That
helped.
was rhetorical, John. He didn't really want a whole
Well,
explanation
you know,
about it.
Mike Enzi, Republican. There was a former Congressman, Tito Roncalio, who was also from Rock Springs, Wyoming, so it helps.
Okay. With that introduction, Dr. Bertagnolli, the stage is yours. Please, welcome. Turn the mic on, please.
There we go. Chairman Sanders, Ranking Member Cassidy, and members of the committee, thank you for considering my nomination to be Director of the National Institutes of Health. It's an honor to appear before you today to share my vision for the NIH. I want to thank President Biden for trusting me with this nomination and Senator Barrasso for the very kind introduction. I also want to thank my husband, Alex, and my 2 children for their unwavering support and unqualified love. I grew up on a ranch in southwestern Wyoming. My early inspiration was my uncle. He was a primary care physician whose practice included traveling across the entire state, it's a big state, to provide expert care to veterans. And it was his devotion to his patients that inspired me to pursue medicine. Like millions of Americans, when my father had cancer, the care he needed was hundreds of miles away. So I have seen firsthand what it means to deliver care to those living in rural communities. I've spent my entire professional life working to improve cancer prevention and treatment. I've done this as a surgical oncologist, researcher, as a professor of surgery, helping to train the next generation of doctors and scientists. As a physician scientist, I've run major clinical trials, helped to advance innovative research, and pushed hospitals and institutions to make sure that the most effective treatments are available to all patients. And for the past year, I've had the tremendous privilege of serving as the director of the National Cancer Institute and working toward the President's Cancer Moonshot goal to end cancer as we know it. My experience has given me great appreciation for the inner workings of NIH and for what more is possible. Recently, though, I found myself in a different position as a patient when I was diagnosed with breast cancer. I was fortunate to have my cancer diagnosed very early. I have completed my treatment. My prognosis is excellent. I also had access to outstanding care, knowing full well that not every patient has that same chance. Most importantly, every treatment I received was supported by NIH-funded research. I am grateful beyond words to the patients who joined the clinical trials before me, the doctors and researchers who were able to use that information to make the best decisions. There is so much that excites me about the possibility of leading the extraordinary team at NIH if confirmed. First, there has never been more potential for progress than what we have today. We just need to harness it. NIH can and must support research that is equitable and accessible to all populations. And this includes dramatically increasing clinical trials that reflect the full diversity of Americans, because we know that's what yields the best results. We should capitalize on new innovations in uncovering fundamental biology, in health information technology, and in exciting new data analytics. And we must interrogate the broad range of behavioral and social science challenges we face today, while laying the foundation to address new issues that will arise in the future. Second, we have an unprecedented opportunity to embrace and increase access to innovation. As a physician researcher for more than 30 years, I have seen the transformative power of NIH research to produce results that save lives. But I've also seen the patients whose prospects were compromised by preventable factors. We should be able to guarantee that the American people are getting a return on their investment by ensuring that healthcare innovations are available and affordable for everyone. Finally, we must restore faith and trust in our nation's top scientists. I am committed to ensuring that NIH continues to be the steward of our nation's medical research and a force of innovation and discovery. But we must also continue to support education in all fields of biomedical research and to inspire young people to become doctors and scientists so that our critically important work will continue for generations. None of this NIH can do alone. I look forward to partnering with Congress and many others to advance discovery and apply the results of our research to better the lives of every American. Again, I want to thank you for the opportunity to appear before you today, and I look forward to your questions.
Dr. Bertagnolli, thank you so much for being with us. Let me begin the questioning by picking up on a point you just made and you put in your written remarks as well. You said, and I quote, and goes without saying that everybody here wishes you the very best in your struggle with breast cancer.
Thank you.
You said, and I quote, "Every treatment I have received was supported by NIH-funded research," correct?
Correct.
Can you give us some idea, based on your expertise, about how much treatment for breast cancer costs in this country today? Somebody has breast cancer over a period of years, how much is it going to cost?
Chairman Sanders, that is a widely variable result. I truly could not give you an estimate because breast cancer is incredibly complicated and can range anything from, a simple surgery to
Right.
years and years and years of very extensive
Would
therapy.
I be wrong in saying that for some individuals, it will cost hundreds of thousands of dollars for treatment?
I believe that is correct.
What do you say, as a physician yourself, to somebody who is undergoing treatment for a drug or treatment that was developed by taxpayer dollars that they can't afford or are going to go deeply in debt to pay for? What does one say to a person to say, thank you for your tax dollars developing the drug, but I'm sorry you can't afford the treatment you need to stay alive? How does one respond to that person?
Yes, Chairman Sanders, I have to tell you that I have sat in clinic next to patients of my own who, for one reason or another, could not afford their treatment. It is a tragedy. I sincerely appreciate you championing the cause of affordable and accessible care for all Americans, and if confirmed, I will work with you to the fullest extent of my abilities to also ensure that that is the case.
Well, thank you for your thoughts. Let me be rather specific. If you are confirmed to be the next NIH director, will you commit to reinstating and expanding the reasonable pricing clause in NIH contracts? In other words, if the federal government puts money into the research and development of a drug, will you insist that the price that that drug is charged in America is not higher than it is charged in other countries around the world, given the fact that we've paid for the research and development?
Chairman Sanders, I can say that I myself believe that the American people deserve a fair return on the investment that Congress has placed within the National Institutes of Health and the research that we do, and I will commit to working to make sure that the benefits of our research are affordable and available to all the American people. I cannot give further specifics at this time about the execution of that plan.
So you're not prepared to tell us that when taxpayers spend billions on a drug, they will not be asked to pay the highest prices in the world for what they paid for?
Chairman Sanders, I am more than prepared to say that I will do whatever I am able to make sure that affordable and accessible care is available for everyone who needs it.
Dr. Astellas and Pfizer are charging Americans with prostate cancer over $165,000 for Xtandi, while the exact same drug can be purchased in Japan for just $20,000. $165,000, $20,000 in Japan. This is a drug that was developed by NIH-funded scientists at UCLA. Do you think the price of Xtandi is reasonable? Should we be paying 8 times more for a drug that taxpayer dollars developed than the people in Japan?
Chairman Sanders, my focus is on making sure that the American people have access and availability and can afford the health care that can save lives, and that is what I will make a commitment to.
Right now, we pay by far the highest prices in the world for prescription drugs. The results are higher insurance premiums, higher hospital costs, and millions of people not able to get the drugs they desperately need. Will you commit to us that you will work to make sure that Americans do not pay higher prices for prescription drugs in this country than people around the world?
Chairman Sanders, it would be a great honor to be able to work with you to make sure that the American people have access to the care that they need to live long and healthy lives.
Okay, my time is up. Senator Cassidy.
I defer to Senator Collins.
Thank you very much, Senator Cassidy. Welcome, Doctor. The National Cancer Institute that you currently lead has the largest budget and research program of the 27 institutes and centers at the NIH. Cancer research is vitally important, and I strongly support it. I'm interested in how you will balance NCI priorities while making NIH-wide budget decisions. For example, President Biden's budget request proposes a substantial increase for the NCI, but it flat funds research for Alzheimer's disease and diabetes, which collectively affect more than 40 million Americans. If confirmed, how will you balance your background in cancer research and your leadership at NCI with the need to be fair in evaluating agency-wide priorities?
Oh, thank you for that question, Senator Collins. And I will say that, first of all, if confirmed, my commitment as NIH director is to the health and vitality of every single American. But I can give you some specifics to address your specific question. You know, how does a cancer surgeon really lead an organization that deals with the huge spectrum of conditions that the American people face? I have two answers to that. First, as a cancer doctor, I took care of patients of all ages, all walks of life, all different health states. I am very familiar to working with colleagues in cardiology, in mental health, in opioid use disorder, in kidney disease, to take care of my patients with cancer. And I feel very comfortable engaging with the broadest possible team of researchers focused on bringing health to people. But second, one of the things that to me is the most exciting about the opportunity to lead the organization is the fact that so many of the diseases that we are working on, individual diseases in our relative silos, really have many common elements. The need to have care access to every community, but even down to the biology. So my field of research was in inflammation and how inflammation causes cancer. Well, guess what? Inflammation is one of the major inciting factors behind Alzheimer's disease, behind autoimmune disease, behind long COVID, behind arthritis, so many things. So both on a scientific level and on the taking care of human beings level, I'm really excited for this opportunity to lead NIH.
And as you know from our discussion in my office, I would like to see NIH fund more projects and more research looking at the role of inflammation in Alzheimer's disease, for example, instead of just funding amyloid plaque, important though that is, research. We've had that discussion. My time's growing short, so let me switch to diabetes. Along with Senator Murray and Senator Shaheen, I had the honor of co-hosting again this year the JDRF Children's Congress this summer. And the NIDDK director, Dr. Griffin Rogers, said that with continued research, it's possible to imagine that people could lead a life free of the burden of type 1 diabetes and its complications, which is very exciting. So we have, as you know, a special diabetes program that is up for renewal, and this committee has overwhelmingly approved its reauthorization. I want to make certain that you understand that that program is intended to supplement and not supplant the regular appropriations. Part of the program goes for type 1 diabetes. Part of the program goes for type 2 diabetes with a special focus on Native Americans and Alaskan Americans. So I'd like to hear your reassurance that you do understand that's additional funding.
Oh, thank you, Senator. I will just say that the researchers and team at the NIH are deeply grateful for the resources we get from Congress that allow us to serve people. And embrace with the greatest enthusiasm particular communities and efforts that focus on serving people. So thank you.
Thank you.
Senator Murray.
Thank you very much. Welcome, Dr. Bertagnolli. Really nice to see you, and thank you so much for your willingness to take on this position at a really critical time, because as you know, NIH has an absolutely critical mission supporting medical research and making groundbreaking discoveries that really help everyone stay healthy and keep our nation competitive and give patients hope for the future. So really appreciate your being here and your willingness to go through this process and lead this agency. The agency also does really critical work in coordination with a lot of other agencies to protect public health and prepare for our nation for pandemics and a lot more. So again, thank you. Let me start by asking you, I know at the National Cancer Institute you've done a lot to address cancer-related disparities for women. So in that vein, I wanted to ask you today, across NIH programs and initiatives, do you plan to strengthen research to specifically improve women's health inequities, including women's midlife health outcomes?
Thank you for that question, Senator. It is very clear that there are many health issues in women that are understudied, that really lack knowledge and deserve to have spotlight shine on them and renewed efforts to be able to provide data to support women's health. I can give you a couple of examples that are really top of mind for me. We have a maternal health, I think it's fair to say, crisis. We had 750 women die either during childbirth or for 1 year after childbirth in 2019. In 2021, it was 1,200. Why? We have to understand that. That's kind of an immediate need that rises to the top. But there are many other things. The whole life cycle of women's health, from childhood all the way through senior adulthood, and that we know women are different. They react to diseases different, and we know that we lack the data to know how to best care for them. So you raise a commitment that something I can easily commit to and say it's very important to me.
Good, thank you. And I'm working with a number of other women senators on some midlife health outcomes. I'll follow up with you on that. I think that's really critical that we look at as well. But let me focus on something you just said, and that's the maternal health crisis. That's something I've spent a lot of time on. It's a huge issue facing women, as you just mentioned, especially since the Dobbs decision. And I wanted to ask you, what can NIH do to improve maternal health outcomes? Specifically, talk about that for especially Black and Native American women who face some of the highest maternal mortality rates in our nation. Can you talk a little bit more about that?
Yes, thank you very much. So I think this raises the issue. It's a twofold issue. It's an issue of understanding how to care for women during the time of childbirth and immediately afterward to make sure that their health is optimal, but it also raises an issue of disparities in access to care and in engaging with people as physicians and caregivers, being able to listen to them, to understand them, and to relate to them. So I think that the maternal health crisis raises not only important biological and medical care issues, it raises really important social issues. We need to understand people and their social makeup if we're going to help them best.
Okay, great. We'll work with following you up on that as well. But let me ask you about the fentanyl crisis and the opioid epidemic. Communities are really, as you know, hit hard by that. The Lummi Nation lost 5 members of their tribe to fentanyl overdoses in just 1 week, and King County has seen a record number of fentanyl overdoses deaths this year. So I wanted to ask you, if confirmed, how will you work to support research that addresses inequities in access to quality mental health care and treatment for substance use disorders through NIH programs, and support those underserved communities that are really harmed by the national mental health crisis and the rising rate of opioid overdose deaths?
Yes, thank you very much for your championing this issue. I myself have lost patients to the opioid crisis. So I've seen what it does. Absolutely devastating tragedy for our communities, and it has increased so much over the last years and disproportionately affects certain communities, although really is spread across the entire spectrum of our nation. I can commit to working with you and on continuing the great awareness that the NIDA has for understanding this issue deeply in ways that bring solutions to the people who need it. Like many things, it has to do with not only medical care and understanding better treatment, it deeply has to do with getting that treatment to the people who need it.
Thank you. Thank you very much, Mr. Chairman.
Thank you. Senator Cassidy.
And I defer to Senator Tuberville.
Thank you, Senator. Doctor, thanks for being here. Congratulations on your nomination. Before I start, I'd like to say a little something about your nomination. It's really nothing against you. I'd like to take the opportunity to draw a comparison between this nomination and other nominations pending in the Senate. Ones that I'm holding from passing by unanimous consent. Your predecessor, Dr. Collins, was approved by unanimous consent in 2009, only 4 weeks after being nominated. The Health Committee did not even hold a regular hearing like this. You have faced a much different confirmation process. Your nomination was held up by Chairman Sanders, which is his prerogative. We have had no confirmed NIH director for 21 months. Back in June, Chairman Sanders publicly vowed to oppose your nomination until he received the administration's comprehensive plan on lowering drug prices, which we all know that's what he's about, and a lot of us are about. As I recall, he promised to hold up not only your nomination, but all health-related nominations going through the Health Committee. As a senator, he has a right to do that. He wanted a policy concession from the Biden administration, and apparently he got one. I was one of the many who want us to have a confirmed NIH director. A lot of people have wanted us to have a confirmed director. It's not unusual, but I don't remember any Democrats saying the sky was falling because we didn't have a confirmed NIH director, because this is a very important position. I don't remember Democrats calling the chairman names or even threatening. I don't remember anybody wanting to change the rules of the Senate because of it. I didn't really say a word about it. If it weren't for hypocrisy around this place, I don't think we could have anything to do. Chairman Sanders got what he wanted. On September 8th, Chairman Sanders announced that the White House met his demands, and he announced this hearing. Chairman Sanders used his prerogative as a senator. I don't have all the details of the concessions the Biden administration made to Chairman Sanders, but I respect his rights as a senator. Frankly, I appreciate Chairman Sanders' defense of the legislative branch. We ought to legislate around here. That's what we were sent here to do. We weren't elected to just outsource our jobs to Joe Biden or any other president. The chairman and I don't agree on everything, but at least he is standing up for what he believes in and the power of the Senate. So I'll get off my horse now and ask you a question. This very, being an educator, this really touches me here. The NIH funded a recent study about the psychosocial functioning in transgender youth after 2 years of hormones. According to the letter NIH sent to Ranking Member Cassidy and me, the research seeks to understand the physical and psychosocial effects of medical intervention to evaluate the effectiveness of existing medical treatments already in use among transgender youth. As you know, 2 young people committed suicide who were part of this study. That's obviously a tragedy. But what concerns me even more is the fact that the NIH was funding this research. And beyond that, I believe the NIH even called the study a success. That's sick. It sounds to me like the NIH totally dropped the ball on quality control and oversight. So, if confirmed, how will you make sure nothing like that ever happens on your watch?
So first, Senator, I really thank you for your affirmation of the critical importance of NIH and what we are, and that we are here to serve the American people, and just how critical that is and how important this job is. And to that end, in response to your question, we have the greatest responsibility to ensure 2 things. First, that we serve all people, all walks of life, and that we really are here to achieve the health of all. But that number two, any research that we do that involves human beings, people, is conducted according to the highest ethical principles so that we make sure that the research is intending to do no harm, to achieve benefit, and is done in ways that have maximum respect for the dignity of people. If confirmed as NIH director, I will affirm to you that that will be my mode of action and my highest priority for all human research.
Thank you. One more quick question, Chairman. The NIH used to be universally respected, non-political organization before COVID, but that trust has been broken, especially in rural parts like my state of Alabama. You're from a rural Wyoming, so you get the rural perspective and you understand just how much people in those parts of the country in particular have lost confidence in our public health institutions. They feel totally overlooked. You know, what would you do as NIH director to help gain back some of that respect in rural areas?
Thank you so much for that question, and I'll be very, very brief. Two things. Number one, I believe deeply in the doctor-patient relationship. That is incredible value. That is trust. A patient comes and puts their life in the hands and their health in the hands of their doctors. And anything that we can do to strengthen the doctor-patient relationship is something that we should pursue to the fullest extent possible. And then second, I believe in education at all levels, being very, and relating our patients joining us in research to the fullest extent possible. Not science here and people here, but people joining us to do science. I think that also engenders great trust in the process if it's done in a respectful and appropriate way.
Thank you. Senator Kane.
Thank you, Chair Sanders, and congratulations, Dr. Bertagnolli. I'm happy to support your nomination. Every time a representative of the NIH comes before us, I ask for an update on the Recover initiative. Congress provided NIH with $1.15 billion in funding to advance understanding, prevention, and treatment of the long-term effects of COVID, including long COVID. And this is a topic very important to me because I live with a mild form of long COVID. Because I've been public about that, I hear from people every day. In this body, I have colleagues, former Senator, former colleague Senator Inhofe, Senator Young, have talked about long COVID experiences. My wife went to a lawyer last week with a friend of ours to help her file for bankruptcy because her treatments for long COVID that knocked out her balance now leave her in a situation where if she doesn't file for bankruptcy, she could lose her home. I was at an event Monday and a technology CEO came up and talked to me about his wife's experience with acceleration and deceleration of her heart rate, which is a fairly common long COVID symptom. About 5.3% of Americans now have long COVID, and of those, that group, 80% suggest that their long COVID significantly limits life activities. Americans depend on research coming out of NIH to help understand how to treat, cure, prevent symptoms that are often debilitating. And it frustrates and saddens me to hear how many long COVID folks who are dealing with it have both had a negative impact on their life, but often face skepticism and disbelief as they describe their symptoms to employers and others. And I'm also frustrated when I hear long COVID sufferers indicate that NIH isn't doing enough on the issue and that their voices aren't being heard. Let me tell you what patient advocates tell me. That NIH isn't considering the input of those living with long COVID in the design and enrollment of long COVID clinical trials, that NIH is not as responsive as it should be to advocate outreach, that with Recover being spread across multiple institutes, there's lack of clear leadership and the initiative lacks kind of a point person that's held responsible for decision making. There's a lack of transparency in the budget and future plans for the initiative. Dr. Bertagnolli, I know your work in the Cancer Institutes has not put you directly into this space, and so your knowledge of the inner workings of the Recover initiative are limited at this time. But should you be confirmed as director, I ask that you continue to work with me to address the concerns of those living with long COVID, including that you commit to meeting with patient advocates to discuss these issues.
So, Senator Kane, thank you very much for that question. And I can absolutely confirm that I will work with you on this issue. I think this is one of the greatest tragedies we have recently seen. And I'll tell you one thing that is something I live by in my research. I love the expression, nothing about us without us. This comes from the people with lived experience community. Maybe we call them the patient advocates. And I love that expression because it really is the way we need to do our science. It not only are we then serving them because we're listening to them, but all the other issues of trust and accountability and respect for the people we serve happen when you do that. So you've hit something that it goes to my core, and I'd be delighted to work with you.
Thank you very much. Next topic I want to ask you about is pediatric cancer research. Along with Senator Moran and 13 other bipartisan members of this body, of this committee and the full body, we introduced a bill called the Gabriella Miller Kids First Research Act 2.0 to reauthorize a program that is aimed at combating childhood cancers. The legislation is the result of continuing efforts by the Miller family to fight childhood cancer, and their revelation to me 10 years ago that of the NIH research budget, only a very, very tiny percent, less than 1%, was devoted to pediatric research in the cancer space. I'm pleased to say that the bill was voted out of the committee last month with a very strong bipartisan support. I know you're familiar with the challenges in combating childhood cancer in particular. As Congress looks to reauthorize the critical program, can you tell me how NIH will continue to expand its efforts using data sharing to speed up research, for example, particularly for childhood diseases such as pediatric cancers?
Yes, thank you. And this has been a major focus of my work since coming to NCI and would absolutely be carried over at NIH. And I just, since time is brief, the beautiful, beautiful Gabriella Miller, when she looked into that camera, I'm sure you've seen it, looked into that camera, and I'm paraphrasing, I don't remember exactly, but she looked in that camera and she says, "Quit talking, get working," or something like that. It just gets to your heart, and we take that very seriously, and that's what inspires us to go forward.
Thank you very much, I yield back.
I defer to Senator Marshall.
All right, thank you, Senator Cassidy. Mr. Chairman, I want to submit for the record first is an op-ed in the Washington Post, April 11th, 2002, by a Democrat senator from the great state of Indiana, Senator Birch Bayh, and of course, one of my boyhood heroes, the late great Senator Bob Dole from the state of Kansas. And it's an op-ed about the Bayh-Dole Act. And I'm sure, Dr. Bertagnolli, you're familiar with this, that this entices the private practice to seek public-private research collaboration rather than focusing on its own proprietary research. If confirmed, will you commit today to uphold the integrity and intent of Bayh-Dole?
Thank you, Senator. And if confirmed, I will commit to uphold the integrity of the Bayh-Dole Act.
Thank you. Next, I want to talk about research. In 2022, nearly half of all NIH funding went to institutes in just 5 states, and they happen to all be on the coast. I think that when we center all that research in 1 or 2 geographical locations, you have incest, you have a decreased randomness of thought, and it pickles things up. The University of Kansas Cancer Center, second to none, NCI designated comprehensive cancer center since 2012. The Kansas State University received NIH funding in 21 to support it becoming a national leader in emerging infections. Children's Mercy Research Institute in Kansas City, advancing the genomic medicine, developmental behavioral health, and pediatric brain cancer research. Will you commit to actually correcting these issues so innovative research in the Midwest are equally prioritized?
Thank you, Senator. And not only will I commit, I can give you an example of where my past work has really already tried to achieve this. When I ran a cancer clinical trials group, one of my main goals was to make sure those trials reached as many communities as we possibly could. And we partnered with a wonderful physician practice in Laredo, Texas, serving the border community, a wonderful physician who served the Oglala Sioux community at Pine Ridge Indian Reservation, and a wonderful oncologist in my own hometown of Rock Springs, Wyoming. So I agree with you completely. NIH research has to reach everywhere, and there are many, many centers of great excellence that we should have the ability to engage.
Okay, well, my next question is a lot tougher one. And Dr. Bertagnolli, you and I both protect a very honored profession. And when I think about the horrors of medicine, the great horrors of medicine, the things we got wrong, you think of bloodletting. I'm afraid that 100 or 200 years from now, those same historians are going to go back and compare irreversible mutilation of adolescents for transgender surgery, irreversible emphasizing, and giving them irreversible medication is going to be one of those two horrors that they're going to be talking about. They're going to be talking about bloodletting and the horrification of disfiguring surgery for people that 80% of them just in a couple more years, once they have some hormones of their own, are going to say, maybe that wasn't a good idea. And before you answer this question, I want you to think about the oath that you and I took. And it's way overquoted, but it's above all, do no harm. Above all, do no harm. So here's my question. Should taxpayers fund gender reassignment experiments or research that are purely cosmetic, where you destroy healthy tissue and organs, or when they use FDA-approved products off-label with significant negative irreversible impacts? Again, this off-label use isn't treating diseases or illnesses. Should taxpayer funds be used to do research or fund these irreversible, horrifying, irreversible procedures and the use of these hormones off-label?
So, Senator, thank you very much, because it's very clear that you share my concern over the well-being of the LGBTQ community, especially young, vulnerable people. What I can tell you is that if confirmed, I will commit to leading NIH to conduct the research that will achieve the very best health for these vulnerable and special individuals.
Sorry to cut you off, but right there, do you believe that it's okay to fund this type of research where these irreversible procedures are being done? Do you think there's any experiment that you can think would justify irreversibly damaging these poor little boys and girls who are 14, 15 years old? Will you fund that type of research?
Any research that we do, Senator, with regard to human subjects has to be done in a way that does no harm and produces the maximum benefit to the people that are participating in the research. And that will be the principle with which I approach any research, especially for this vulnerable population.
Thank you. I yield back.
Senator Smith.
Thank you, Chair Sanders and Ranking Member Cassidy. And thank you so much, Dr. Bertagnolli, for being here. It's wonderful to see you again, and I'm just delighted to have the opportunity to support your nomination on this committee, and also as we move you forward to confirmation. I'd like to actually follow up on something that Senator Barrasso started with and focused on, which is your personal experience in Wyoming, experience in rural America. I'm not going to ask you about the ranch, although I'd be tempted to. But I think it meshes with a very clear policy interest of mine, which is around rural health and a focus on rural health. And we know that in healthcare settings across the country, there's a real shortage of healthcare workers, and that this effect is really felt particularly intensely in rural communities that are struggling to maintain hospitals and maintain access to care. Now, we've had some important innovations over the last several years. I would point specifically to telehealth as a way of delivering care. But could you please just talk with us a bit about, as you think about your own personal experience in rural communities, how can the NIH ensure access to the most advanced medical research and other treatments, regardless of, and especially if you live in small towns and rural places in this country?
Well, thank you so much for that question. You know, our job is not done if we just produce an effective treatment or an effective approach. Job is not nearly done. Our job is only done when people are living long and healthy lives, free from and And so that means that a critical area of NIH research needs to be healthcare delivery research. And I'll just give you a quick personal note. Town where my parents lived in central Wyoming, no hospital within 100 miles. Through state, community, federal, and tribal participation, there's a new hospital being built there. And I am committed to seeing that new center in that new location be brought into the research enterprise so that we can understand how these kinds of federal, state, tribal, community partnerships can be brought to bear to be able to deliver better care. Just one example.
Well, that's great, and I appreciate what you're highlighting, which is the importance of partnerships, but also the real importance of NIH attention to training and research opportunities in rural communities, because I think there's a lot of good data to show that if you are trained in a rural place, then you're much more likely to stay in that rural place, and there are good examples, good best practices for how to do that. And I have to say I share Chair Sanders' concerns about our challenges delivering care in this country. And so I think there's lots for us to work on there. Another area that I want to just touch on before I wrap up is the importance of focusing on research around mental health care. This is something that, again, is a very, very important issue to me. Less than 5% of the NIH's health budget goes to the National Institute of Mental Health. So less than 5% of the overall budget, while 1 in 5, or about 20% of Americans, are going to experience some sort of mental health issue every year. So, and we know that mental health and physical health are not like two completely separate things. It's brain health and the rest of your body health. So could you talk a bit about how you view the NIH's role in focusing on that connection between mental and physical health, brain health, and the rest of your body health? And given this low percentage of funding, how can the NIH advance research on mental health?
Oh, thank you. I think, first of all, mental health affects every single disease we treat.
Yes.
You know, it affects how someone can manage their cancer journey. It affects how somebody who's got kidney failure is able to get the needed care. It affects every single thing we do. So one of the things that I'm really excited about, if confirmed, on taking on the role, is to really focus on all of these interactions between the various institutes where there are common themes that need to be addressed even in order to treat these individual diseases. Mental health is overarching and really needs to get into every research institute. That's number one. And then number two, that will also help us best leverage the funding that goes into the to the Mental Health Institute, being able to pull on that through resources throughout the entire NIH. And thank you for your advocacy and raising this really important issue, raising awareness.
Thank you. Thank you very much, Mr. Chair.
Thank you, Senator Cassidy.
I defer to Senator Budd.
Thank you, Ranking Member. Thank you, Chairman. Dr. Bertagnolli, thank you for being here. Congrats on your nomination. It's a great state you come from. You know, research tells us that children in the womb respond to and that they can feel pain at 12 weeks. And fetal anesthesia is recommended for surgeries at 13 weeks. So, Doctor, before obtaining consent for a fetal tissue donation, will you commit to requiring NIH contractors and grantees that they explicitly inform mothers that their child will feel pain during an abortion by 12 weeks of pregnancy?
Thank you for raising this issue, Senator. I believe that the policies and procedures that govern any research with fetal tissues really prohibit any discussion whatsoever with the mother toward even the possible use of such tissue for research. So it would not be acceptable for me to affirm this, that interaction is not allowed to take place.
Thank you, Chairman. I yield back.
Senator Hassan.
Thank you, Mr. Chairman, and thanks to you and Ranking Member Cassidy for this hearing. Dr. Bertagnolli, it is so good to see you, and congratulations on your nomination. Thank you for your willingness to serve. I want to follow up on a line that you heard from Senator Murray and just now from Senator Smith. The National Institute on Drug Abuse at the NIH plays a vital role in responding to emerging trends in substance use and addiction. This institute has contributed substantially to our understanding of medication-assisted treatments for opioid use disorder and helped validate the effectiveness and safety of evidence-based medications to treat addiction, such as buprenorphine. As a result of NIH's leadership, buprenorphine is now widely accepted as a gold standard of care for individuals struggling with opioid use. Last year, I worked with Senator Murkowski to pass into law the Mainstreaming Addiction Treatment Act, which eliminated an unnecessary hurdle for providers who are prescribing buprenorphine and further expanded access to this life-saving treatment. However, despite this push to increase access, research shows that high levels of stigma and lack of provider education still stand in the way of individuals receiving medication-assisted treatment. Doctor, can you tell us how you will develop strategies to eliminate the stigma around medication-assisted treatment?
Oh, thank you for that question. And yes, I think that the overall issue of substance abuse is, first of all, it's a tragedy, and second of all, that tragedy is compounded when on top of it there's also stigma associated with the disease. So that stigma needs to be combated at every step. I always fall back to what is the first and most important relationship. That's the treating physician and the patient together. I think trust between those two individuals is absolutely key, trust and support. But then I also think we can do more to raise community awareness, in every regard. And this is yet another area of what's the best way, the most respectful way, the most appropriate way to garner community support for our individuals battling substance abuse. This is another really important area of research to make sure that we know how to do it respectfully and well.
Well, thank you. Will you commit to continuing to grow the National Institute on Drug Abuse's work on treatment for substance use disorders?
I will commit to working with you to fully pursue work at NIH to end the scourge of substance abuse.
Thank you. I want to move to a different topic. Antibiotic resistance is a serious emerging threat to global public health. In July, you and I discussed the NIH's important role in antimicrobial resistance research and development. We need to work together to encourage the development of new medications that are able to treat infections that are unresponsive to current antibiotics. Doctor, how do you envision NIH's role in the public-private partnership to combat antimicrobial resistance?
Certainly, this is a critical issue for drug development and which has been successful in a long time to a certain degree in being able to head off the continual problem of antimicrobial resistance. And I fully support any research that can help us get to that aim for people. I'll also add that, like virtually everything we do in medicine, there is also a social and an educational component to this, right? So it's not just finding a new drug to beat the bug. It's making sure that prescribing practices for antibiotics or use in agriculture, all of these other efforts that really can make the problem worse and perpetuate the problem also need to be an area of our research to be able to combat.
Well, I thank you for that. Are there other new strategies that you could be looking at to improve clinical trials for new antimicrobial medications? Because I understand the last point you made, but I think we also need to make sure that we're continuing the research so that we have new classes of these medications.
Yes, thank you. This is a very important issue for clinical trials. I will also just take it as a side to say we have so much work to do in the clinical trials arena. And one of the other commitments I want to make is for clinical trials, since it's been one of my core expertise, that are faster, more inclusive, more responsive to the needs of people. It's one of the major initiatives that I'd like to see happen at NIH.
Well, I appreciate that. I just also want to look forward to working with you. I'm interested in bipartisan approaches to support innovative antimicrobial research, including through leveraging the tax code, and I really look forward to working with you and the rest of the department to achieve this goal. Thank you, Mr. Chair.
I defer to Senator Murkowski.
Thank you, both to the chairman and to the ranking member. Doctor, thank you for being here and taking our questions. I appreciate the response that you've just provided to Senator Hassan about clinical trials. I am very invested in and very focused on what is happening within clinical trials for ALS. I've got a personal connection. I think so many of us do have a personal connection, and we recognize just really the horrific progression of that. And I will submit to you a pretty specific question about how we can make ALS clinical trials more efficient, looking for perhaps alternative sources to better or more precisely measure ALS progression. But it is what you have just said about leaning into this and placing a priority on it is something that I appreciate, and I'd look forward to further conversations with you on that. You've already responded to questions that I had. Senator Smith asked about rural health. That's obviously something that, coming from Alaska, we would certainly encourage greater research in rural areas that don't have care delivery sites. One of the other issues that I wanted to bring up was what Senator Murray raised with menopause research. I was able to meet with some advocates just a few weeks ago, and it's just shocking to me to know that one of the life stages in women, whether you like it or not, is menopause, and how little we actually know about the impacts and many of the treatments for adverse health conditions that are associated with menopause in particular. Let me ask my question about infectious diseases. We in Alaska are plagued and have been for a long period of time, but it continues throughout our state. We see preventable chronic infectious diseases, particularly tuberculosis and hepatitis C. As of 2021, Alaska had the highest incidence of TB in the country. Again, we have very rural areas. Hep C, the rates there have been increasing statewide now for 2 decades, despite the availability of the curative treatments. I have been in small rural airports and run into public health workers that are there just solely and specifically to monitor what we're seeing with hepatitis C. So I would ask how the NIH would approach coordinating with other federal agencies, whether it's the state, the local, the tribal governments, to do more with eradicating these chronic infectious diseases, not only tuberculosis and hep C, but the sexually transmitted infections as well, because again, this is an area where we see rates that are, in my view, beyond intolerable. So whether there are possibilities for cheap point-of-care testing for STI, talk to me a little bit about what progress we could make or what we could hope for.
Oh, yes. Thank you, Senator. I'm not an infectious disease specialist, and I was not previously aware of these unique features of the citizens of Alaska.
It's rough.
Yeah. I can comment briefly, though, and say that certainly for hepatitis C and tuberculosis, and perhaps even for sexually transmitted diseases, that the 2 keys to managing when it's prevalent within a population are diagnosis, detection. I mean, hepatitis C can be silent for decades, and people don't realize they have it, so they don't get the proper treatment. The same with tuberculosis. Many workplaces institute routine screening. Certainly if you work in a hospital, you get screened every single year, and it's through that screening and to identify individuals that need treatment are a really important part of control. instituting the best approaches for that. Again, I have to defer to colleagues who are experts in infection control, but I would be very pleased, if confirmed, to work with you to address these specific issues for the people of Alaska.
Well, and we do have some great experts that are on the ground who are very familiar with this, but it's the coordination that I'm hoping that we will be able to see between federal, tribal, state, local. So thank you very much. Thank you, Mr. Chairman.
Mr. Chairman, thanks very much. Dr. Bertagnolli, thank you for putting yourself forward for this position, especially at this time with so many challenges that we face as a nation. For more than a decade, I've led the annual bipartisan appropriations letter advocating for funding for the National Institutes of Health, most recently working with Senator Tillis on a letter that was joined, where we were joined by 56 other United States senators. And at the end of that letter this year, we say, and this is just quoting one part of the letter, quote, "If we are to continue grappling with emerging threats as well as improve the health of Americans and the quality of their lives, we must continue to invest in biomedical research that has the potential to save money, improve lives, and offer an economic return for our nation." So we're proud to be able to do that, and we'll continue to advocate for robust funding for the National Institutes of Health. I don't have to remind anyone the reach and the scope of the National Institutes of Health. They literally touch the lives of every American. And we're at a time where there's both enormous potential for advancements in health science, but also great, great challenges, such as the risk of disinformation and the decreased trust in medical experts. The National Institutes of Health in my home state of Pennsylvania provides tremendous value despite those challenges that I mentioned. Pennsylvania researchers successfully compete for thousands of grants each year, totaling over almost $2.5 billion. The funding directly supports more than 28,900 jobs in Pennsylvania and also contributes to a thriving life sciences sector in the state. So we have a lot at stake as a Commonwealth, but also for our country. I want to commend the work that you've done at the National Cancer Institute related to pediatric cancers, diseases which were almost universally fatal decades ago, but which are now largely survivable thanks to investments in research. If confirmed, how will you work to ensure that the NIH is continuing to invest in children's health and that children are being appropriately represented in clinical studies?
Yes, thank you very much for that question. You know, there has long been, I think you recognize that children have been definitely understudied, and certainly the conditions that affect them have not been not received as much attention from the pharmaceutical industry as some adult diseases. What can we do at NIH? A couple of things. First of all, recognizing the importance of developing collaborative mechanisms that bring pediatric cases together for study and knowledge. You know, many pediatric cancers are rare diseases. And one of the great successes that we've had at NCI has been to bring together a community of patients, researchers, and caregivers around bringing together data from those taking care of pediatric cancer cases across the nation. But it doesn't obviously stop at NCI. You know, every single disease center needs to focus on the youngest Americans, making sure that we address their needs with clinical trials that are targeting the diseases that they suffer from. Last thing I'll say, prevention. Prevention is key. All of us need to prevent. Prevention has to start when we're children, right? And so not only targeting diseases that kids have, but targeting new strategies to make sure they get the preventive therapies that can last them a lifetime, I think are one of the strongest ways we can influence their health overall.
Thank you very much, Doctor. I wanted to finally ask you about work that I've done with regard to rare disease patient groups over the years. One challenge that's come up repeatedly is the difficulty in demonstrating that a potential therapy is effective due to poor natural histories of these rare and ultra-rare diseases. Can you talk about the role NIH can play when working with the FDA to support research into rare diseases that can help advance our understanding and support the development of safe, effective therapies?
Yes, thank you, Senator. I can give you a very specific example of this one. The NIH Clinical Center is an absolute treasure. There is a program at the NIH Clinical Center today that I can speak to most easily because it has to do with pediatric cancers that takes very rare people with very rare pediatric tumors, assembles a team all the way from basic biology to clinical trials, importantly has and partners, public-private partnerships and partners to bring together a community to be able to treat that disease. Those individuals all come to the clinical center so that from throughout the nation, it's incredibly moving when you see people who have a rare disease or children with a rare disease, their families there, for the first time meeting another person who has that really rare disease. It's an incredibly moving experience, and that community built around that, centered around our clinical center, is making tremendous progress one by one. I'd like to see that model scaled dramatically.
Thank you, Doctor. Thank you, Mr. Chair.
Senator Cassidy.
Hey, Dr. Bertagnolli. I got lots of questions, so if I interrupt you, please be tight with your answers, and if I interrupt you, I apologize in advance. You said during your staff interview you support the reasonable pricing clause included in the recent contract with BARDA, but you were not familiar with the NIH experience in the 90s. Clinton administration NIH Director Harold Varmus stated when rescinding the policy, extensive review indicates that the pricing clause has driven industry away from potentially beneficial scientific collaborations, and eliminating the clause promotes research that enhances the health of the American people. Research America, an alliance of hundreds of organizations advocating for biomedical research, expresses concerns about the policies that would, quote, discourage the uptake of breakthrough discoveries by the private sector. This would be detrimental to patients. Would you apply reasonable pricing clauses to NIH contracts if confirmed?
So, Ranking Member Cassidy, my absolute utmost priority would be securing effective treatments.
Now, that's not my question.
Affordable.
My question.
So,
would you apply reasonable contract pricing clauses to NIH contracts?
I cannot commit to any specific action at this time.
I'm asking you to commit to not an action.
But I will work with you on this issue because I share your desire to make sure people have access to the treatment.
Well, of course, my concern is, based upon Dr. Varmus's experience, that if you do institute, you're going to stop the translation of basic research to taking care of patients. This is not something that we need to kind of pussyfoot around. History tells us that if you do it, patients are damaged, despite whatever rhetoric would be out there. So I hope that you would be more forthright in your kind of embracing this issue. We've got scientific evidence. My gosh, if we're doctors, we should actually look at the evidence, not listen to the rhetoric. I say that because I know that patients are going to be damaged by this, and that should be our highest calling. I don't mean to rag, but I just get frustrated. Okay. Also, what about march-in rights? You mentioned that you want to lower costs. People argue for march-in rights. Your predecessor, Francis Collins, consistently said during his tenure that the NIH does not have authority to use march-in rights to lower drug prices. It goes against congressional intent if you only use it to lower drug prices. Do you support using march-in rights to lower drug prices, quote unquote?
Again, Ranking Member, I cannot commit to any particular policy right now. And
now that is, though, it specifically says in the law that you're not supposed to use it. It gives you 3 ways to use it, and one of them does not include lowering drug prices. I mean, we're just asking you, are you going to follow the law? That would be the action.
I will follow all the laws of our land, certainly. And again, my goal will be to make sure that people get the treatments that they need.
Sounds good. Sounds like, with that answer, it sounds like you're answering my previous question that you wouldn't do the other thing. Let me ask you about another issue. Secretary Becerra chose not to continue an NIH Ethics Advisory Board reviewing extramural fetal tissue research for appropriateness during the previous administration. And presumably, a panel like this would help achieve what you tell me your preference is of ensuring fetal tissue is only used as a last resort. I am told there were members of this board who supported fetal tissue research, but still rejected some of the research projects put forward by NIH for the board's review because of a lack of informed consent. Now, you stressed the importance of informed consent in an earlier answer. These pro-fetal tissue advocates rejected these proposals because of the lack of informed consent, but Secretary Becerra has discontinued this board, providing that safeguard. Do you agree with Secretary Becerra's decision to not continue this board?
Senator, I do not have enough information about those specific actions to really comment on Secretary Becerra's decision. What I can affirm for you is that any research needs to be conducted according to the most stringent ethical principles.
I accept that, but this board was making sure that was the case, and it rejected some of those. It was the mechanism by which what you were telling me was actually executed. The informed consent was not done. If we stipulate as a theoretical that what I laid out the facts are correct, would you support reinstituting the board?
Again, I can't comment on the specifics of that activity. I can just say that if confirmed, I will uphold the principles of ethical human research.
It's been 4 years almost since the COVID-19 pandemic began. We still actually don't know where the virus originated. Many studies and reports have explored plausible alternatives. Experts agree that further research is needed. Do you believe the federal government should do everything it can to determine the cause of COVID-19, including the possibility it emerged from a lab that was conducting gain-of-function research?
Ranking Member Cassidy, I think no one wants to know what the true origin of the last COVID pandemic was more than the biomedical
And how will you
research
accomplish
community.
that?
To the fullest extent of our ability to gather the data and have access to the data and make a valid assumption.
And making it public?
Make data that we have available public and accountable to the American people, yes.
Okay, I yield.
Senator Baldwin.
Thank you, Mr. Chair. Dr. Bertagnolli, welcome to the HELP Committee and congratulations on your nomination. A number of us on the HELP Committee are also on the Appropriations Committee, and I want to address the budget for the fiscal year 24. Despite the challenges that we had faced in writing a labor HHS appropriations bill, because it included the availability of less funding overall than we had in fiscal year 23, our bipartisan fiscal year 24 bill builds on our longstanding commitment to NIH and biomedical research in general. We secured critical increases in our bill for some of the agency's most important programs, $100 million increase for mental health research, $100 million increase for Alzheimer's disease research, $60 million increase for cancer research, and $12 million for a new palliative care research program. So as a cancer researcher, I wonder if you can describe how the recent investments in NIH and specifically in cancer research have advanced care for patients and improved outcomes, but I also want to challenge you to talk about the impact that the House passed, I'm sorry, not the House passed, the House bill that's pending that has drastic cuts in biomedical research, how you would tackle that if that became law.
So thank you, Senator. First, let me say that I speak for everyone at NIH to say that we are deeply grateful for what we receive from the federal government in order to conduct our research. And then number two, let me speak as a physician to say that over my 30-plus years of being a physician, I have seen the tremendous advances that have been made as a result of NIH funding. I'm not going to take down the clock in the many advances that have happened just in the last year. Just let me assure you that people are living better, longer as a result of NIH research. I think that you are also asking to address how changes in funding will impact what we do. I will just say that every penny we get, we will use to the fullest extent possible to secure health for the American people. We will focus on the issues that Congress brings to us as important, and I really embrace working with you on those key issues. And then finally, if our budget, there is a chance that our budget will force us to leave opportunities on the table, because the opportunities are enormous. And I'll just leave it there.
Okay. There have been 2 biosafety incidents involving the H5N1 virus at the University of Wisconsin-Madison. In both cases, there was a lack of guidance and oversight from NIH, which I find very, very concerning. As chair of the Labor HHS Appropriations Subcommittee, I worked to secure language and funding focused on this issue in our bipartisan fiscal year 24 bill. In addition to directing NIH to articulate the roles and responsibilities of investigators and institutions conducting this research, the fiscal year 24 bill would establish for the first time an office at NIH to serve as a resource and to provide tools and guidance to the research community. Dr. Bertagnolli, what steps would you take to enhance the oversight of NIH funding research involving potential pandemic pathogens?
Thank you very much for your advocacy for this very, very important issue. You know, potential pandemic pathogen research stands to achieve great benefit for people by allowing us to respond immediately and save lives, but it also has risk. And I can commit to you, if confirmed as NIH director, that I will fulfill the highest possible oversight for programs that engage in this kind of research, not review and oversight, to make sure that they are conducted safely and achieve the benefit we know we can see for the American people.
Thank you, Mr. Chair.
Senator Markey.
Thank you, Mr. Chairman, very much. Let me just begin by saying that LGBTQ people are living in a national state of emergency. More than 1 in 2 transgender and non-binary youth have seriously considered attempting suicide. When elected officials use their bully pulpit to target gender-affirming care, create barriers to evidence-based life-saving treatment, and fuel the fire of the youth mental health crisis, this is a driving force in a nationwide campaign of discrimination, and it is unacceptable. To LGBTQ youth, young people, let me just say this very clearly: trans rights are human rights, and I'm never going to stop fighting for essential research and investments in the care which you need to make sure that everyone is free to exist as their authentic selves, and we won't rest until you are free to live openly, authentically, and safely. Doctor, thank you for being here today. I've heard from many people in Massachusetts, including many oncologists, about your excellent work and your leadership, and it's clear that you have a commitment to public investment to drive research that will improve Americans' health, treat illness, and to cure disease. Last year, Congress passed my bipartisan Children in Media Research Advancement Act, requiring the National Institutes of Health to conduct research on technology and media's effects on infants, children, and adolescents, and provided the NIH with $15 million to launch this program. We already know that big tech's exploitation of younger users is driving a mental health crisis, and this research will further document the serious harms caused by the online platform's insatiable appetite for children and teens' personal information. Doctor, if confirmed, will you commit to prioritizing that research? We have an epidemic, a mental health epidemic amongst teens and adolescents in America.
Thank you, Senator Markey. As the parent of very recently teenagers, I can certainly comment to a great concern about the amount of time spent in front of computers and worry of a parent as to what that really is doing, I can commit to you that this is a very important issue for NIH research, understanding what this new technology means for our young people, really everyone, but certainly more of a focus on the young. I also know that this is an issue that is a great concern for our Surgeon General, and I also look forward to working with others across HHS on this issue.
Yeah, the Surgeon General has identified the problem. Senator Cassidy and I already have, coming out of the Commerce Committee successfully, an upgrade of the protections for kids online up to age 17, and we're hoping to move that on the Senate floor. But we also need the documentation from NIH as to the underlying pathology which is being created as we sit here right now. Since the passage of the National Alzheimer's Plan Act and Alzheimer's Accountability and Investment Act that Senator Collins and Senator Warner and I have worked on, NIH research has contributed to significant advancements to understand and treat Alzheimer's, yet we have a ways to go. We are just beginning to understand the impact of air pollution and environmental justice on the brain. Black, brown, disabled, and rural Americans face discrimination and other barriers to access to treatment, including expensive treatments or long travel times to care. And family caregivers still struggle every day with providing care to their loved ones with Alzheimer's. Doctor, can you just tell us how you view the NIH's role in continuing to lead Alzheimer's research in new directions, center equity and access, and support the family caregivers who are so often at the front lines of providing care?
Thank you so much, Senator, for that question. You know, it raises many issues that I'll just go back to maybe my core approach to things such as this. First, understanding the biology of what produces this condition. And that means going all the way back, maybe even to the very early years of life, so that we can think about prevention rather than treatment. That's really critical and encompassing a very broad population of people to inform that. Next, though, dealing with what we have today. People who are really suffering, families for which this is a tremendous burden and having difficulties. Developing new treatments that can work now for people suffering from the disease. And as you've already said, it is part of NIH to think about care delivery, and that means delivering for the caregivers, taking care of the caregivers, because they're a really important part of what helps us achieve health.
Thank you. And again, our goal is to continue to increase funding for NIH. Research is medicine's field of dreams from which we harvest the findings that will give hope to families that we can find a cure for Alzheimer's. And NIH is really the National Institutes of Hope for all those Alzheimer's families. Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Last week, the House Oversight Committee subpoenaed acting NIH Director Tabak for documents relating to the investigation of Dr. Moran's. Dr. Moran's, a top advisor to Dr. Fauci, is accused of using a personal email to avoid public accountability. And according to him, delete anything he did not want to see in the New York Times regarding the origins of COVID. The subcommittee released emails allegedly from Moran's and requested information in June and again in September. If confirmed, will you comply with any subpoenas the House sends to you relating to the origins of COVID-19?
Oh, thank you, Senator Braun, and I just can reassure you that I take Congress's responsibility for oversight for the NIH, and if confirmed, my responsibility as director of the NIH to be compliant with policies regarding that oversight extremely seriously. I can confirm that if I assume the position to be accountable and transparent and to work with you to resolve these important issues.
And have you ever spoken to Dr. Moran's about the COVID-19 pandemic?
No, Senator, I don't know Dr. Moran's.
And will you commit to not use a personal email for official NIH business or to try to shield conversations from the American public?
Yes, Senator, absolutely.
And also, I'd like to comment before I got one more question for you. Senator Hawley and I actually passed legislation asking the White House to release all the material they hold in classification on the origins of COVID-19. There's a law out there, and they have not complied with that. We're still trying to get them to comply with that law. And remember, you're working for that administration. So this one is a question in terms of any relationship you've got with Big Pharma. I think you have received millions of dollars from Big Pharma to support your research, and you've sat on the board of several companies receiving stock options and bonuses. Our country relies on its public officials to have their best interest in mind when performing their duties as public servants. How can the American people be sure that as NIH director, you would be focused on the job at hand rather than boosting the business of any past associates in the pharmaceutical industry?
Thank you for that question. I just want to confirm for the record that the funding that I received from pharmaceutical companies was to conduct research, that none of that formed my own personal salary. The only salary I received during that work was from Brigham and Women's Hospital, a salary set based on my academic rank. I have one instance of receiving a payment directly from a pharmaceutical company. It was for service on the board of directors of a single pharmaceutical company. And so, but finally, the more important question, I completely agree with the need to have one goal, one constituency that I am serving, and that is the health of the American people.
Thank you for that. One quick final question here. I think you've signed an agreement with Senator Warren about what you might do after this post. And from the information I've got is that you won't seek employment or compensation from any pharmaceutical company. Is that correct? And does that mean then if you do, you will turn down those offers?
The agreement with Senator Warren is designed to assure the American people and Congress that I will act with the goal of the very best interest of the American people if confirmed for this job. And I have agreed for a time of 4 years after stepping down in government that I will not accept employment at a major pharmaceutical company.
Thank you very much.
Senator Hickenlooper.
Thank you, Mr. Chair. And thank you, Ms. Bertagnolli. Really appreciate your service and be willing to step in at this key time. Emerging technologies, AI is top of mind. They're becoming ingrained into various parts of our lives. Healthcare is absolutely no exception. AI is primed to assist with trial design, real-time monitoring, predictive analysis, go down all the different aspects of clinical trials, which are so expensive. I think we all have agreed over a long period of time that the cost is a barrier to progress. So, Dr. Bertagnolli, do you think that the advent of AI will help create efficiencies in our clinical trial systems, and are there particular pitfalls we should be mindful of when considering technology in trials?
Yes, thank you very much for that question. Machine learning approaches, artificial intelligence, are really wonderful new computational methods that we're all very, very excited about. You know, we've long had the scale of data that we just do not allow us to analyze it properly. However, the more we learn, the more we use these techniques, the more we realize that they have to be like any tool used in a very careful and responsible manner, particularly when it comes to human research. So the short answer is yes, absolutely. This is very exciting, but with a qualifier that the design and conduct and type of data used to train these models need to be very, very carefully considered to make sure we're getting the results that really matter and are meaningful for all people.
Any specific pitfalls that you'd want to put on the record?
I think that, I guess the most serious one that we hear about a lot is an AI method that might be designed and trained on one particular ethnic group or one particular category of people who have perhaps more access to treatment than another, and then it gets a result that continues to disadvantage others who need to be included in that kind of research. I think that's one really serious one, but there are many. It's a computational method after all, and it has to be doing what we want it to do.
Right, and oftentimes the algorithms aren't as transparent as some of us might like.
Exactly, thank you.
Harvard and Brigham and Women's Hospital created the Multi-Regional Clinical Trials Center. Obviously, you're very familiar with, given your time at both institutions. The center's prime focus is improving the safety and efficacy of global clinical trials. They've trained representatives literally from dozens of countries on what is good clinical process and what is good clinical practice. This leadership, I think, is critically important, often underestimated, the significance of it. We live in an interconnected, wonderfully diverse world, but that interconnectedness and diversity does have its own challenges as well. And I think we should be making sure that we utilize all available data to inform our research decisions. So what more do you think that NIH could be doing to encourage the use of safe and rigorous global clinical trials?
Thank you for that question. I actually have personally conducted global clinical trials in the area of cancer, and that was done through the use of very careful protocols that delivered data in very careful formats and that also monitored sites so that we knew exactly what care was being delivered as part of the trial that was testing a treatment. For things that really matter, that level of quality is very, very important. I'll just add parenthetically, though, there are other things that we can do in public health globally that don't necessarily need to fit into that very tight model. So we should look at everything that we can to help inform our work.
Could not have said that any better myself. And I think Dr. Bertagnolli's eagerness and optimism is a reflection of her Western roots, which I have great appreciation for. And I have other questions, but I will submit them on written record and thank once again the witness for being here and for your commitment to public service and turn it back to the chair.
Thank you. Senator Lujan.
Thank you, Mr. Chairman, to our ranking member for this important hearing and this conversation. Dr. Bertagnolli, it's an honor to be with you today. And I want to begin by recognizing and thanking you for your help in providing archived data from the National Cancer Institute regarding radiation exposure from atmospheric nuclear testing in Western states, especially as we have an opportunity to provide more support for these families across the country. I'm very honored to have worked with Senators Hawley and Senator Crapo with the support of 61 of our colleagues for the inclusion of these provisions in the National Defense Authorization Act. Thank you for that as well. Dr. Bertagnolli, the Institute Development Award, IDEA with a small e, if you will, program plays a huge role in building capacity in biomedical research across the entire state of New Mexico. For example, the New Mexico Networks of Biomedical Research, which are located on the New Mexico State University campus, provides a collaborative biomedical research environment for more than 10 other institutions across my state. Despite the program targeting half of the country, IDEA's budget is around 0.9% of the overall NIH budget. If Congress were to provide additional funding specifically for IDEA, how would you, as NIH director, expand the program?
Well, first of all, thank you, Senator Lujan. First of all, I'd be delighted because as I think you've already heard in this hearing, I really want to see NIH research expand to encompass all of our country, not just a few advantaged locations. And I would look forward to expanding that program, not only by partnering with the outstanding academic institutions within the IDEA states, as they grow out their educational and research outreach programs, but also for programs that we have that are national infrastructure, such as the National Clinical Trials Network and other infrastructure that literally goes down into individual communities. So it would be very welcome and quickly applied into action.
I appreciate that. And on the same note, do you support increasing IDEA program state participation across other major research programs beyond the currently available mechanisms to programs such as those supporting biomedical research facilities, instrumentation, and training?
Yes, Senator, I view this as one way we can engage more of the American people in the research that we conduct, and I think it would be very positive.
I appreciate that. You touched on this with your previous response around clinical trial diversity, and I appreciate your commitment to increasing clinical trial diversity participation. An opportunity still exists to increase diversity among research staff that would have implications for diversity and research participants. A clinical research workforce that itself is diverse is better able to prioritize, connect, care for, and successfully recruit a diverse participant population in research. How will you ensure that NIH is granting funding to clinical trial research staff that reflect the people impacted by the study conditions?
Yes, thank you. This is a priority. It is a priority. Why? Because we know that, as you've already alluded to, a diverse research staff, like a diverse care staff, brings excellence, really brings better outcomes for the people that we serve. How are we doing this specifically? Targeting programs to identify very talented individuals who come from diverse backgrounds, giving them opportunities to participate, and then supporting them through educational and other support programs to make sure that they succeed. And there are numerous efforts like this across all of NIH, and I would like to see this expanded even more.
I appreciate that. And Mr. Chairman, I have some other questions I'll submit into the record, and I yield back.
Thank you very much. Senator Cassidy, you wanted a second round?
Yes, please. Dr. Bertagnolli, you had said that you had maintained the Biden administration's policy for allowing fetal tissue research, but that it should only be used as a last resort. How could you ensure that fetal tissue is only used as a last resort?
Thank you, Senator. You know, understanding the great sensitivity of many people and passionate feelings of many people on the issue of fetal tissue research, I would want to be very respectful of that. Again, if confirmed as NIH director, my job is to serve everyone, including the communities who care deeply about how that tissue are used. Absolutely, I would follow the laws of the land in every aspect, and I would also follow within the laws of the land. The dictate is we're trying to achieve maximal good for people. We're trying to cure major diseases. That's our highest goal, but we need to do it with respect and
let me ask,
follow the law.
Because that slippery slope, we're doing this for an end, and therefore the means are justified. The specific question was, how would you ensure that fetal tissue is only used as a last resort?
Thank you. I would follow our principles of review and oversight over the use of this tissue, which I understand is very stringent and asks that particular question as by the review boards as one aspect of approving its use.
Okay. Now I'm going to ask you some questions related to obesity. My state, unfortunately, is 50th or 49th in terms of obesity. I'm told that the amount of funding directly for obesity, and by the way, we know this, but just for context, obesity is a major driver of health disparities, disproportionately affecting the poor, those of color, but also whites. And it is a major driver of morbidity from heart disease, from cancer, from COVID-19. We know that. I'm told that the funding at NIH that's specific for obesity is only about roughly 1.2 billion a year, or about 2.5% of the budget. Again, but a major driver of health disparities and of morbidity and of all the things that you and I know of. Arguably, funding for obesity is lagging way behind funding for other conditions relative to its impact upon society. How can we better address this issue? Would you commit to increasing funding for obesity? How do we better address the foundational, translational, and implementation of research for obesity?
Thank you, Senator. Thank you very much. I will say that from my current position as the director of the National Cancer Institute, obesity and the rising obesity epidemic is one of the major causes of cancer in the United States. We recognize this. And there's been a tremendous amount of work done by NCI to identify the etiology of this, how obesity drives cancer, and how that can be overcome. So I can't speak to the way the funding has been distributed now, but I can assure you that this is yet another one of those topics that does not belong in a silo, for which we've got to work across all of the institutes that can have a piece of owning this problem. And then the last thing I'll say, again, stigma. Making sure that people who suffer from this condition are respectfully included as being part of the solution to the problem.
I accept that. One suggestion, I'm told that nutrition obesity research centers have kind of, a funding which is kind of stagnant. And just to increase that funding would be a place to start. Again, if we're talking about something which is driving cancer, heart disease, hip replacement, you name it, why not? I used to tell my medical students, obesity is here and it has a hydra head. But we seem like we focus more on the manifestations than we do on the creature itself. If we address the creature itself, we address all these. That seems to have been lost. If you could address that, that would be great.
If confirmed, I would be really delighted to work with you on this. I agree that this is a very serious health problem that takes a multifaceted approach, and agree that it is something that we need to work on and would love to work with you on.
Thank you. I yield.
See, I knew, Senator Cassidy, that if we waited long enough, there would be an issue we would agree on. And obesity certainly is an epidemic. It's impacting diabetes and a host of other issues, and something this committee must and will deal with. There's an issue that we didn't touch upon today. I have raised my deep concerns that there are many millions of Americans who cannot afford the outrageous cost of prescription drugs in this country, and that is something that the NIH must deal with. But there's another issue that we didn't talk about, and that is that we look at the global situation. We look at developing countries and millions of people throughout the world who are struggling to feed their families. What we find is that many of the prescription drugs consumed are consumed in the developed world, that poor people around the world cannot afford the medicines they need. Medicines, by the way, which may cost a few cents to produce. They don't get it, and they die or they suffer. Sorry. All right. Okay. Thanks. Last May, President Biden announced that the U.S. government would share some NIH-funded COVID patents with the World Health Organization to expand access in low and middle-income countries. If confirmed, will you build on this commitment and make sure that medicines developed with NIH dollars are accessible and affordable in low and middle-income countries? Will you ensure NIH-funded technology is shared with manufacturers in developing countries so that they can produce the medicines their people need at a price they can afford?
Senator, I can confirm that I share your concern. I share your passion for bringing life-giving care to not just the United States, but the world. And I will work with you on this issue.
All right. I would hope that you would appreciate that in some cases, these drugs cost a few pennies to manufacture, and yet they're not getting it to people for whom it might be life or death. that is something that you will pay attention to?
I will confirm that I will be very delighted to work with you on this issue. It is critically important.
Okay. Well, thank you very much, Dr. Bertagnolli, for being with us today. That concludes our hearing. As a reminder, the committee will have a markup next Wednesday, the 25th, on this nominee and a few others. For any senators who wish to ask additional questions, questions for the record will be due tomorrow, Thursday, the 19th at 5 p.m. Committee stands adjourned.